As the patient improves, he will eventually need to be weaned from the life pulse. The goal in many cases will be to wean the patient back to conventional ventilation at much less support than the patient was on before beginning high-frequency ventilation. However, ideally, the patient can be weaned directly from the life pulse to nasal CPAP. There are a few guidelines for weaning. Wean the life pulse slowly. The life pulse is a very gentle form of ventilation, much more so than conventional ventilation. Therefore, weaning the patient back to conventional ventilation too soon is ill-advised. Second, maintain optimal mean airway pressure. During patient management, the mean airway pressure should be kept as low as the patient's pathophysiology allows without compromising oxygenation. As the patient's condition improves, blood gases will indicate that conventional support can be weaned. However, be careful about lowering mean airway pressure too low. Third, lower the life pulse PIP. As weaning begins in earnest, reduce the PIP in increments of only 1 to 2 centimeters of water, unless the CO2 is below 40, in which case you must lower the PIP more aggressively, perhaps in increments of up to 5 centimeters of water. But be careful about weaning too quickly on the peak inspiratory pressure. Small changes in PIP and tidal volume can have very dramatic effects on CO2 and oxygenation during high-frequency ventilation, whether you're increasing or decreasing support. Fourth, adjust the PEEP or CPAP. The PEEP or CPAP may be adjusted as necessary to maintain adequate PO2, alveolar inflation, and mean airway pressure, which may decrease as PIP is weaned. Don't worry about lowering PEEP or CPAP until FiO2 is 30% or less. Again, PEEP and CPAP are the safest, most static, stable pressures we apply. Much safer than FiO2. Fifth, lower FiO2. Begin more aggressive weaning of FiO2 when you're comfortable with the patient's mean airway pressure. Remember, if you're using a separate blender to provide gas to the life pulse, you must adjust both blenders so the settings remain equal. Sixth, resume weaning PIP, and do so as tolerated. If the patient begins to deteriorate with further reductions in PIP, the pressure may be near a mean airway pressure threshold. In this case, cease weaning and consider raising the PEEP or CPAP to stabilize the lungs. Resume weaning when the patient is ready, as determined by blood gases and clinical observation. And if possible, you may continue to wean FiO2 during the interim. Seventh, once the high-frequency PIP is down to approximately 15 centimeters of water or less, and the conventional rate has been decreased, hopefully reduced to CPAP, or as close to CPAP as possible, the patient's chest rise will be much more an indication of spontaneous breathing. That is, his own spontaneous breaths will be much more aggressive, much bigger than the jet chest rise, which is usually the case anyway, but especially when you're weaning. Eighth, wean to nasal CPAP. If the patient is stable on low life pulse and background CV settings, and the patient is breathing on his own, try the patient on ET CPAP. If tolerated, you may want to extubate the patient directly to nasal CPAP. And remember to match the nasal CPAP at the mean airway pressure the patient was on at the point that you weaned. Ninth, remove the life pulse for cleaning and in preparation for the next patient.